Hello everyone! Welcome to another webinar from the Steps Forward Innovation Academy. Today, we'll explore resident and fellow well-being. Our experts here are here to give a big picture view of the current well-being approaches for residents and fellows with a focus on understanding challenges and ideas within your organization. This webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult a professional advisor for specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA. And let's just take a moment to go over your experience today as an attendee. If you're joining us here on Zoom, you will see a dark menu bar either at the bottom or the top of your window. There you can access a selection of resources related to this webinar, including links to our Wellbeing Toolkit and today's slides. There's also a link to stepsforward.org where you will find all of our past toolkits, podcasts, and webinars. If you don't see those options, select the three-dot-more button to access the resources and the Q&A. If you're joining us on YouTube or LinkedIn, welcome. You can follow the link in the description to join us here on Zoom, access the resources, and ask questions for our speakers to answer. After our webinar concludes today, you will be able to claim 0.75 continuing medical education credit hours. You can follow the link in the resources tab to the AMA Ed Hub and claim the credit there. Also in the resources, you will see a link to our upcoming webinars. Check out the programming we have planned for the rest of the year and register there in one step. We'll remind you of all this at the end, but for now, I would like to introduce you to today's speakers. Joining us today are Dr. Laura Hanyok and Dr. Maureen Leffler, and our moderator, Kira Ng. Kira, I'll pass it over to you.
Great, thanks, Alec. Welcome, everyone, and thanks for joining us today. Whether you're tuning in from your program, taking a moment between clinical duties, or listening on the go, we're so glad you're here with us. My name's Kira Ng, and I'll be moderating today's discussion. I currently serve as the director of the AMA's Joy in Medicine Health System Recognition Program. I'm really excited about today's topic on resident and fellow well-being. Residency and fellowship are incredibly demanding phases of medical training. And while they're filled with growth, learning, and meaningful patient care, they can also come with intense pressure, long hours, and emotional strain. So prioritizing the well-being of our trainees isn't just a luxury. It's necessary for professional longevity and the sustainability of the physician workforce. Today's webinar is going to cover a variety of topics related to resident and fellow well-being. Our speakers will talk about why and how to take a systems approach to well-being, what specific needs learners have, and how to identify a way to meet those needs, including who you might need to partner with inside your system to optimize this work. And lastly, they'll share how to select metrics to evaluate the impact of your work. I'm really excited about today's speakers. They bring a wealth of knowledge and experience to this area, and I've personally learned a lot from them. So I'd love to briefly introduce them. Starting with Dr. Laura Hanyok. She is an associate professor of medicine in the Division of General Internal Medicine at the Johns Hopkins University School of Medicine. She currently serves as the assistant dean for graduate medical education, in which she leads efforts to promote well-being for approximately 1,300 residents and clinical fellows at Johns Hopkins. She also works on accreditation, program oversight, as well as supporting trainees, program directors, and faculty. Dr. Hanyok's previous leadership roles include serving as Director of Interprofessional Education at the Johns Hopkins School of Medicine, where she co-developed a curriculum for over 400 learners in medicine, nursing, and pharmacy. She also was previously the Continuity Clinic Director and a core faculty member in the Johns Hopkins Bayview Medical Center Internal Medicine Residency Program, and she is a clinical preceptor in that program and a practicing general internist at Bayview. We're also lucky to have with us Dr. Maureen Leffler, who currently serves as the Chief Wellbeing Officer at Christiana Care in Delaware. Prior to her role at Christiana Care, Dr. Leffler served as the first Chief Wellbeing Officer at Nemours Children's Health, where she led the organization through an enterprise assessment of well-being, implemented a peer support program, and expanded the scope of resources available to support the needs of Nemours associates. In 2020, Dr. Leffler was also named the co-chair of ACGME's National Task Force on Wellbeing and responding to the COVID-19 outbreak. She and her team have developed a national GME wellbeing community, which continues to convene on a bi-monthly basis. So with those introductions, I'd like to dive into today's program. Doctors Hanyok and Leffler, over to you.
Great. Thank you so much, Kira. Hi, everybody. It's so nice to be with you all today. My name is Mo Leffler, and I'm going to kick us off. Next slide, please. Great. So Laura and I put together this webinar and the toolkit that it really is based on, and we did so thinking about this conceptual framework. So we thought we would start by sharing kind of where we started. And many of you are probably familiar with the Stanford model of occupational well-being. This conceptual framework has been widely accepted and adopted across the world, really, to help shape well-being efforts. And most recently, it had a pretty robust publication about the empiric validity of this model, which lays out 3 domains related to occupational well-being. And the most recent research on this model found that the 3 domains are indeed interrelated and associated with the important outcomes of professional fulfillment and burnout. So I have found this model particularly helpful in shaping and broadening how we approach well-being work and how we think about well-being. It's made it more holistic, and it has, for me, clarified points of intervention. So briefly, I just want to talk about the 3 domains captured in this model because it really does shape how we approach the toolkit. First of all, they describe a culture of wellness or culture of well-being, which is really a culture that's characterized by compassion for self or others, a culture that promotes personal and professional growth, connectiveness, and community. It also emphasizes the importance of workplace systems and practices that promote safety, efficacy, quality, with minimizing inefficiencies and minimizing the amount of time we waste doing things. Finally, it also includes the really important domain of personal resilience, which they actually renamed individual wellness in the most recent study of the model, reminding us that it is incredibly important that we all practice self-care. It is essential. And if self-care is the only way that we focus our well-being efforts, we probably won't be effective in promoting professional fulfillment and mitigating burnout. So that's how we started approaching the toolkit. Next slide, please. I think I'm turning it over to you, Laura.
So with that big picture framework, we then thought, what are the important and unique challenges in a learning environment for residents or clinical fellows that we should all be thinking about and considering when we think about how to create or build upon well-being initiatives for our physician learners? And for those of you who have been in residency or fellowship before, I think these things are probably familiar to you. However, I think it's helpful to think through those when considering what is really important. So I think the first thing, as we know, is residents and fellows have less control and autonomy over their work hours, their schedules, all of those things, and really are told what is the schedule going to be. There's someone typing. I don't know if they can.
Yeah.
Thank you. Sorry about that. The other thing is, of course, if we are working perhaps up to 80 hours a week, not everyone, but if you are, there can be less time for the important lifestyle habits that feed into individual well-being, exercise, adequate sleep, etc. And when you're in training, there's the need to balance clinical autonomy and learning how to be more independent while also being supervised by your attending physicians or others. And that can be a tough thing to reconcile when you're thinking about your own well-being and how to flourish in a learning environment. That goes along, of course, also with the fact that they're learning while also taking care of patients and providing a service. Of course, also when you start residency or fellowship, there may be important personal life changes that are happening, not just things that happen to all of us, but that are specific to their training programs. They're relocating to a new city. Maybe they are in a place where they feel more isolated because they don't have family or friends. And then, of course, when one's in training, there may be more uncertainty just about what happens next in life. And that can add to some of their challenges related to well-being. And then as you're a physician in residency or fellowship, you're adjusting to what your new professional role is. You're developing competence, you're developing confidence in what you're doing as a physician. And doing that while working within a hierarchical structure can be particularly challenging and something that we as those who are creating or building upon well-being initiatives need to think about. And then lastly, you know, as residents and fellows, they may be under a high degree of financial stress, both with the income that is provided when you're in training and also potentially significant educational debt. So these are some of there may be more that are important to you and important to your learners, but things to think about when you're considering what are the background and the needs to tackle around well-being. Next slide, please. So with that, Mo and I put together, as part of this toolkit, what we consider 5 steps to help create and promote well-being for residents and fellows. And we're just going to take a few minutes to go through those with you, go through a brief example, and then finish up from there. But we encourage you, if you're interested, to read through the full toolkit because it does provide additional explanations and other examples. So when you're considering what you might want to develop or add to in a well-being initiative, first, identifying who the key players are, who will be both part of the initiative and leading the initiative. Next, you want to assess the current state of your graduate medical education program, and that may be an individual residency program, an entire GME enterprise within a hospital, but whatever that might be. Then once you have that current state, either through collecting data or making other observations, you want to assemble a working group who will decide what the realistic interventions are that one can implement to attempt to make changes and improvement in well-being. While we're doing all this, it's also important to remember that although self-care individually will not fix everything, we do need to have support in place to make those whatever those self-care modalities are for individuals possible. So making sure that there is institutional support for those different individual well-being needs. And then lastly, measuring and then sharing the impact of what your initiative has developed. And then if you want to, go back to the beginning and start all over again and build upon what you have developed. So we're just going to take a few minutes and go through these different steps. Next slide, please. So first is to identify your key players. And we developed this schematic just to help orient you and think about what the scope and location, if you will, of your well-being initiative may be. So it may be starting within an individual residency or fellowship program, which is great. And if that is the scope of your intervention, then you want to think who those key players are. Obviously, your trainees, but also residency leadership, faculty who work within that department. Perhaps there's a resident wellness group that's already established that you could work with within that residency or fellowship program. Others may think on a scale that is a little different, and perhaps you work within a GME office, or depending on your school or your institution, excuse me, maybe you're working in an Office of Academic Affairs or other hospital-wide office. When you're thinking about that, you also want to consider other key players that may be partners with you. Maybe you have a student health office if you're part of a university. Maybe there is an overall, well, there should be a resident or fellow council within your sponsoring institution. So whether that resident council is someone that you want to partner with, or if there's already some other kind of GME-wide programming that may be offered either by your group or by others, and thinking that those could be your key players. And then, of course, you also want to think even more broadly within your hospital or your health system or your university, if you have a chief wellness officer, or if you have others within human resources or within the hospital setting, other executive leaders for whom this is their focus and their scope, how can they be your partners when you're thinking about our residents and clinical fellows? How do we incorporate perhaps some of the larger either health system, human resources, et cetera, work in wellness for our residents and fellows? Next slide, please.
Thanks, Laura. So for step 2, we thought that we would start at what seemed a logical place, which is the beginning as far as we're concerned, which is getting to understand the current status of your GME program. And we thought we would share some of the more common and resident and fellow specific broad stroke assessments that we're aware of, and then encourage you to also think about getting various sources of information, because it's really important to keep in mind that there is really no one-size-fits-all solution. Individual programs have unique challenges and different needs, and to be most effective, we believe that it's important to understand where you're starting, get really clear on the specific needs of your program and address it with a thoughtful intervention to meet those needs. So some of the broad stroke assessments that are available to you, usually for free, and we know are specifically available for residents and fellows, include the ACGME Wellbeing Survey data, the AMA Organizational Biopsy, the Wellbeing Index from the Mayo Clinic, the Stanford Professional Fulfillment Index, and the Mini-Z resident version. So the ACGME Wellbeing Survey data is probably one of the broad stroke assessments I get the most questions about. This is included in the annual ACGME surveys. However, it is distinctly separate from any data collected related to accreditation. So this data does not impact the accreditation process through the ACGME. There's a firewall between them. When you get your ACGME Wellbeing Survey data, you get information about both faculty and trainees. And the information can be used to understand 4 different domains: engagement, emotional exhaustion, workload, and meaning at work. So this is available to every organization, and there is national data because they collect it from every training program in the country. So you do have some comparison data. It's not specifically diagnostic, but it can be helpful to flag certain programs, or if you're concerned about a program, it might affirm a concern and really prompt you to intervene. The AMA has a wonderful tool, the Organizational Biopsy, which is available for free, and there's a lot of comparison data for residents across the country. The Stanford Professional Fulfillment Index was actually validated for residents by leaders through the AMA several years ago, and that measures work exhaustion, interpersonal disengagement, burnout, and professional fulfillment. And lastly, the Mini-Z is also available specifically for residents, and it measures burnout, stress, and satisfaction. So these are large global measures, and they might give you a pulse check on how your program is doing, but we think it's really important to then take it another step and understand the very specific needs. What are the systems drivers of professional satisfaction or burnout that maybe you can intervene upon? And there's a couple ways of doing this. You may think about doing an inventory to understand what needs are being met, what gaps there are. You may think about doing listening sessions, which can be formal or even informal through rounding, and putting all of that data together, again, using multiple sources of data to understand optimal areas to intervene and use your information to design interventions appropriately. Next slide, please.
So with that information, you then really want to decide on what the focus and scope will be of your intervention, whether you are starting something brand new or building upon something that already exists. So to that, you want to first assemble your working group. So kind of looking back to the first step to get a sense of who the key players are and what the area of influence, if you will, you want your key players to have. So really thinking about, I think those who are within residency education more commonly. So obviously our residents or fellows, your program leadership, your graduate medical education office, but there may be others depending on what the topic area is that you really want to get involved as well. So maybe that's the employee health group. Maybe that is the peer support program that exists in your hospital. Maybe it's the chief medical officer if you're really focusing on electronic health record innovations to reduce, reduce pajama time or reduce unnecessary tasks. So think about who those people might be. Obviously, they want to be people who have an interest in doing it, have time to focus on it, and also have the ability to influence whatever intervention this may be. And then really just make a plan to start what that might be, building upon what's already in place or starting brand new. It's really okay to start small. And I think that actually helps to get some early wins, decide what works, see how the team works together, and being okay and actually focusing on using existing resources if they are already out there, because that helps to save some time. And if you were starting this 15 years ago, there wasn't as much necessarily out there about opportunities to improve well-being. There are more things that are out there now, and we'll share a little bit later. Sometimes you need to make the case for support, whether that is financial support, time, other things. So we encourage you to go back to from step 2, what is the data that you have that shows that you need to make an improvement? And are there other stories that you can tell to help make the case for whatever those additional resources might be? Next slide, please.
Thanks, Laura. So step 4 is to ensure that there's institutional support for individual self-care. So going back to that Stanford model, we know that the majority of professional satisfaction and burnout, probably the majority of opportunities to improve it probably lie in the culture of well-being and the efficiency of work domain. And we also know that it is essential that we make sure we have support in place for self-care and that we prioritize it at our organizations. Going back to the slide that Laura shared about what the unique needs are related to GME, it's a good reminder about why we are really obligated for GME to make sure we have these supports in place. We're working with a population who is going to work a lot. They're often in a new area, and they're often in an area where they don't have their pre-existing support structures around them. So making sure that we have a lot of things in place for them when they arrive to start a rigorous training program is optimal. We also know that personal wellness means a lot of different things to different people, and we're really obligated to have a diversity of resources to meet lots of dimensions of personal wellness, physical, emotional, social, relational, spiritual, financial. Thinking about personal wellness broadly, having stuff in place at the jump for your trainees who are going to show up and have to adjust to a lot of new things is really important. We wanted to specifically call out the importance of physical and emotional health resources. These two domains can really suffer when our trainees are working as hard as they are and often trying to balance other major life adjustments. So things like free memberships to local fitness centers, or ideally to a fitness center at the hospital or the health system, can be great. We know that medical students, residents, and fellows are at an increased risk for experiencing anxiety and depression. So we really emphasize the importance of having 24/7 access to mental health care. Opt-out mental health check-ins have been found to increase the likelihood of GME folks actually following through on getting some mental health support. And sometimes we don't need mental health care specifically, but we do need some support through things that are emotionally distressing to take care of our own emotional health. Peer support can be really helpful for this. Peer support programs should be made available to your trainees, and maybe even figure out ways for program directors, coordinators, or trainees to be involved in peer support programs. And coaching is a great tool, which has some evidence behind it for being a particularly effective well-being intervention for physicians. So having said that, please do not forget the importance or leave out the importance of individual self-care and personal wellness resources while broadening your strategic approach to include systems-oriented stuff. Next slide.
So the last step in what we have described in our toolkit is really measuring and then sharing the impact of intervention. So when you think about doing this, you want to collect data that is useful for your audience and defining who that audience would be. That may be going back to some of those higher level global assessments that Mo described in step 2 and getting that data perhaps on a yearly basis to see what the impact may be. That also may be going back and collecting qualitative data if you did listening sessions, for instance, earlier on to see what the impact may be. There may be other data that already, I don't want to say already exists, but that is already available for you to collect or to access, things like electronic health record metrics if you're working on something that is focused on how to improve efficiency, for instance. When you think about your audience, you want to know who those people are, and not just things like your residents and fellows and program directors, but are there other people who are key players that are supporting your initiative financially or in other ways? And you want to make sure that you measure what is important to them as well. Now, that's not exclusively to say to focus on who those people are. However, you want to be able to demonstrate impact in a way that's meaningful to everyone that has a role in creating this and executing it. As I earlier mentioned, if there's already data being collected, then by all means, if that's useful, use and leverage that data. It may be the ACGME annual survey, for instance, which is one piece of data that is collected without us needing to do anything. There may be other surveys or systems level data that's being collected. And if you can work with those groups to get resident or fellow specific data, that may be useful for you as well. And then we encourage you to share your success. You may share it in what we would consider more traditional sort of academic means with presentations and research papers and the like, which is of course very important. I also think it's really important to think about locally, how do you share your success? That could be putting it, in my hospital, there's all these screens everywhere that's advertising what's going on. It might be somewhere like that. It may be in local or regional or national news that is going out about your institution. It may be, your residency and fellowship programs putting it out on Instagram for all of their followers to see. So thinking about how you're going to make your success visible and make whatever metrics you might have visible is an important thing to consider. So that's the summary of our 5 steps. I was going to take a few minutes and walk through a kind of practice scenario or example, just to give you a feeling of what that might look like. And then we'll kind of put it all together and close, and we'll be happy to take questions that anyone has. So I'm just going to walk through this that we have on a few slides. So a teaching hospital with about 100 residents and fellows reviewed the results of their annual ACGME survey and found that only 75% reported that they were able to attend personal appointments when needed. The ACGME requires hospitals to allow trainees to attend health appointments during business hours when necessary, and it's a priority for your hospital to help ensure its team members can attend to their own health needs. So we've kind of already collected some of the data that we want to have, which is what our ACGME fellow survey, resident and fellow survey results are. That helps us to determine what our focus might be. Next slide, please. So next, which goes on to step 3, which would be to assemble your working group. In this case, we thought that this would be important to get resident input from the resident council that existed, some program directors who were kind of representative of what the needs might be of a couple of your training programs, and then importantly, one of the administrators who helps to work on all of the schedules of the residents, since that seems important to be able to figure out how to make time off a possibility. And the team decided that, though we didn't specifically talk about setting a goal, I think it's good to think about what would success look like to you. So their goal, their measure of success was that they wanted to improve their survey response over the next couple of years. So it would go from 75% to 95% of the residents and fellows agreed that they had time to attend these appointments. Doing that, they looked at, again, step 3, how do they make a plan to build upon what they already have in place? So in using tools that already exist, we wanted to share the second trial toolkit if others were not familiar with it yet. The second trial is one of a few of what they call surgical education numbered trials. I think they're on 3 of them now, but the second trial was a large multi-center national trial focused on surgical residents and specifically how to optimize their culture to improve well-being. I won't go through all the data, which was very positive overall. What I think is really cool out of this is that they have a free online toolkit that anyone can access to look at interventions that they either created themselves or found from other institutions that you can adapt based on the needs of your program. And they're grouped into different categories. A few, for instance, are meaning in work, resident camaraderie, work-life integration, scheduling, and efficiency and resources. So they have these different topic areas on their toolkit webpage. And if you click on the area of interest, it goes through a number of different options for you to think about if you're trying to work on those areas. So with that, we were looking at guidance from their section, which was dedicated wellness time for residents. Next slide. and then made a plan to start a new initiative to make that possible. So based off of that toolkit, the group, with support from the Graduate Medical Education Office, wrote a policy that designated protected wellness time, that was separate from other sick or other leave time. And then with review was approved by their Graduate Medical Education Council to say that if people need to take time off work, they need to be able to do this. And this is the policy for it to happen. This did not exist previously. They then shared the policy broadly with the programs, with the residents and fellows, importantly with some of perhaps the program administrators and others that may be involved in taking time off. And then they also thought it was important to make sure if people needed time off that they knew how to get in touch with the doctors or other clinicians they needed to see. So they compiled a local resource guide for commonly needed clinicians that residents and fellows could access if they needed to find someone they needed for their own care. Lastly, they chose a measurement that already was being collected externally, so they themselves didn't necessarily need to collect more data. And they found that after the first year, there was some improvement and significant improvement by the second year. So this is just a very kind of quick and short way to think about how to make a change. And you may say, oh, this is something small. This can have a really big impact on people's ability to take time off, to feel that the institution or the hospital supports them to take time off, and that this is being publicized to make sure that everyone knows what the requirements are and that the culture supports them being able to take time off work. So that's sort of a quick summary, and we're happy to talk more about that at the end, if you will. Next slide.
Thanks, Laura. So I think that example does a really nice job of bringing together the things that we thought were important to emphasize. First, understand what the current state is and what the unique needs are. Listen closely to your constituents. That was a great example of listening and identifying a solution that mattered to them. There are lots of opportunities to improve well-being, lots and lots of them, and we really do believe that incremental improvement will lead the way to major changes. It's one of the reasons we also like to emphasize, look at those broad stroke measures like professional fulfillment or stress, but also take time to measure the impact of more focused interventions. I want to reemphasize the importance of strategically meeting the needs, working closely with important stakeholders. This is not any one person's responsibility, but well-being is something we all are keeping in mind as we continue to try to improve the learning environment. It's also not something that happens in a silo. Well-being efforts are most optimal when they're integrated into all the things that are happening. So working closely with partners outside of your wellness committee or even outside of your academic affairs or GME community can be very effective, as can sharing the impact. I personally believe that when we start measuring and showing the impact on well-being of things like changing a documentation process or protecting time for a physical health appointment, when we connect the dots between those operational and procedural changes to the well-being of the constituents that we care about, we are also modeling and leading the way for others to identify ways that we can improve the learning environment and promote professional satisfaction and well-being for our GME community. So communication really is at the heart of this. It's listening, understanding, sharing what we learn, and continually reiterating to keep moving the needle forward. Thanks so much for having us.
Great. Thanks to you both. Appreciate sharing all of that. I think especially struck by the reminder that it's okay to start small. I think that we hear a lot in our work at the AMA from program directors or other health system leaders who are very overwhelmed with wanting to tackle this issue. So I really appreciate that reminder. I'm going to transition us to the Q&A. So a reminder to our webinar attendees that if you have a question, feel free to pop it in the Q&A box and we'll hopefully have time to answer it. We've got about 10 minutes for our Q&A. But I want to start by kind of drawing us out a little bit and thinking about the evolution of this topic, especially over the last 5 years since COVID. The investment by health systems in the well-being of their workforce, we've seen that grow throughout the country. So I'm wondering from each of you, how have you seen the conversation around trainee well-being evolve over the last few years, and where would you like it to evolve over the next few years that we have?
You want to start, or I can go? Either way. I'm curious your perspective.
I'm happy to start. Yeah. One of the things that I have seen that I am very appreciative of and excited about is really an evolution away from just focusing on personal wellness. So I think that the message has been heard loud and clear that although GME participants appreciate attention to them in ways of like trying to create social connections or bring mindfulness activities to them, that is not the solution. And that there's been a greater focus on changing things like the way we do scheduling to protect time for self-care, the appreciation of a diversity of personal wellness needs. We don't have a one-size-fits-all solution for every individual learner. Thinking about putting technology into our GME people's hands to decrease administrative burden. I've also found it encouraging to hear the deep appreciation for the expertise our learners bring in terms of technology and how maybe we can learn from them what we can be doing differently in our learning environments. I think the shift to a more practical, grounded, systems-oriented approach to well-being has been exciting for me.
I would agree. That was one of the thoughts I had as well, that I think when this space really started, it was focused a lot on supporting individual well-being, which again, as Mo eloquently described, needs to happen. However, that's only one piece of this, and that focusing on the systems, and I think actually sometimes linking it to other key priorities, quality and safety, electronic health record optimization, that our residents and fellows recognize that those are really the things that will improve some of their workplace. You know, in my institution, we just started using AI scribing, outpatient and now inpatient, and the residents have been some of the early adopters, and they have seen a big change in their practice. So linking what our trainees need with what physicians in practice need with system changes, I think is a big thing. I also just wanted to mention, sorry, if people may have seen this already, but in academic medicine this month in August, there actually was another piece talking about systems and approaches to improving well-being and going beyond what we're speaking of in terms of national systems, things like accreditation and how we are paid in GME for residents and those sorts of things which impact their well-being. Again, not necessarily anything that all of us on this call, maybe you can, but I can't impact necessarily those things, but to know that there's even another layer to consider. Well,
and I'll add to that one more thing that I think has shifted in such a great way is I do believe that help seeking for mental health and stigma around help seeking has changed, taken a 180. And there's been great work at the national level to change licensure wording. At our state level, there was some legislation that changed in Delaware. And across the country, lots of credentialing forms are changing, which are real systems-oriented ways that we are destigmatizing help-seeking and making it okay to acknowledge emotional distress, get the help and support that we need. And I think that there has been such a huge change in that area for the better.
Yeah, I'd love to expand on that piece specifically around stigma and mental health. You know, I think there can still often be a lot of skepticism, especially from trainees, about the safety for certain resources. So we hear a lot, you know, great, we have an EAP. How can you ensure that this isn't going to jeopardize, you know, my job? So I'm wondering if either of you could speak a little bit about how you can reassure your trainees that when they do access resources that are available to them, especially around mental health, that they, you know, there's no risk to them in doing so.
Yeah, I think that really comes down to messaging and how you share the resource and guarantee that with them. Sometimes, depending on how your mental health resources work, it may be more straightforward. So for instance, where I work, some of that EAP support is actually outsourced, if you will. There's an external company that does that. And I think when we share that with the residents, that may make them feel a little more comfortable knowing that. Though, even if they use local resources, that's one of the important things that we emphasize, that is not part of the reporting structure. Where I work at a university, so actually our residents can get some of their mental health care through what's called the Student Health Center, though they're obviously not students. That is a separate electronic health record, and we explain those things to them as well. So I think that if you can't always make those changes, but if those things are in place, really ensuring that you message to them and providing them resources that are completely external. So for instance, there's a national physician support line that is a peer support program that is completely free to any physician in the country. And they never will, you can call anonymously, for instance. So making sure they know all of those different options.
I'll pivot a little bit to a question we just got in our chat, which is around kind of the financial case or the ROI of investing in the well-being of our trainees. So when we think about well-being of our attendings, our physicians, a lot of times the conversation on ROI is tied back to retention and recruitment. And so this attendee is asking, how do you make the financial case for trainee well-being when you've removed kind of the piece of the puzzle around retention? How have you addressed that in your systems?
A major driver for well-being efforts in that sphere may be attracting your trainees to stay in your system. So I think that can be a very helpful thing to think about. If our GME folks feel valued, seen, cared for, and are part of a system that's responsive to their needs, I think they're more likely to stay. And I think that's one of the things that has been a driver for our program. The other piece of that ROI conversation is recruitment. This is probably trainees ask, how are you going to support me? What resources do you have? How do you do this differently? What differentiates you as a training program? And at Christiana, I feel very grateful for the amazing resources that we're able to offer our trainees. We have an embedded well-being psychologist, a PhD psychologist dedicated squarely to the 300 residents and fellows here. It's a much smaller program, so we're able to do that. But they all know him. He's been here for 5 years. He's a well-known, well-trusted, visible person who they turn to, and he can get them to the formal resources he needs. That differentiates us, and that is really a major driver of folks coming here, along with some of the other unique well-being programming. So attracting trainees and retaining trainees, I think, are two things to consider when you're thinking about the value you will get investing in well-being, among many others.
Great,
Laura, do you want
thanks.
to add to that?
Yeah, Dr. Hanyok.
I would agree with all of those. I think that if you are still working on meeting well-being requirements from external groups, such as the ACGME, that sometimes that also makes your case if it's going to cost money, but you don't want to get citations. Now, that isn't the only thing we should be using to consider what we do in well-being, but if you aren't meeting those external requirements, that is something that also needs to be considered. However, I think the preferred option is to think about what Mo described and really, I think recruitment in particular at our institution, people are asking what these resources are now. And there's, we all want to recruit the best physicians to take care of our patients, so.
Thank you. And just to build on that a little bit, we've seen a lot at the AMA through our recognition program, organizations leaning into that recognition for recruitment and retention of their trainees post-training. So I think to your point, Dr. Leffler, this is a continued priority for a lot of the organizations we're working with and really speaks to what organizations are investing in, and hopefully it's their people. And I think we'll continue to see trainees looking at that as they think about life post-residency. You didn't dive too deeply into well-being champions, but we did get a question specifically about how those individuals are reimbursed, if they're reimbursed. So a lot of times we'll see models of well-being champions kind of being deputized inside the system to sit on councils and to advise in the GME well-being space. So I'm curious, in your institutions, how does that work? How does this champions program work for you? And then is there reimbursement or protected time for that role if someone serves in it?
So I guess I can speak in our GME system, if you will. It's probably different in many places, but Many of our well-being champions are also doing it as part of another administrative role, if they will. So I'm the assistant dean, but one of my areas that I focus on is well-being. So I don't necessarily get protected times only for that, but it is part of a role that is already supported. I think in our residency programs, many of them will designate perhaps an associate program director or a core faculty member who is getting a little bit of protected time for that piece of their work and designate that they should be focusing on that. Now, that's not to say everyone does that. I think that sometimes departments assign people or designate people that way, and they don't necessarily have protected time. But within, and that's on a more departmental level. In our GME space, though, we encourage people to think about who can do that, who does have some protected time. We don't have a separate funding stream specifically for people who are like, that's their only title or role, if you will. Mo, I don't know what you do at Christiana.
Yeah, we don't have GME wellness champions specifically. We do have one psychologist who's known to them and does a lot to support all of the programs. And that person actually reports to me. So I'm the CWO. So we do have the wellbeing team kind of supporting GME efforts through a wellbeing psychologist. However, our wellbeing psychologist works extremely closely with the academic affairs, the DIO and the assistant DIO, all the program directors. And other than that, we don't have in GME kind of volunteer or wellness champions or even a wellness committee. And we have tried to integrate well-being work into the programs through all that they're doing, program directors, associate program directors, etc. We have well-being champions outside of the GME. Some of them are faculty, and they are reimbursed differently. We have some stipend support work. We have some who have a little bit of an FTE offset to do some work. And I'm happy to answer questions about that on the side if that would be helpful.
Great, thank you. Just being mindful of time, so this will be our last question for today before we wrap. And Dr. Leffler, this is for you. So we mentioned during your bio that you serve on ACGME's National Task Force for Wellbeing. So I'm wondering if you could share a little bit about what that is. Is that something that attendees could get involved in if they wish? Just a little bit more about that would be helpful.
Sure can. So I did do that stuff. I no longer do, but I can tell you about it. The ACGME started a National Task Force for Wellbeing in April of 2020. And at that time, we stood up a wellbeing community. Some of you maybe joined our calls in the early stages of the pandemic. And for about the first year, we met every 2 weeks to really understand how things were going in the GME space. We spaced that call out over the past, 5 years now. But the call continues to happen. It has been taken over by Dr. Stuart Slavin, and Bethany Alden continues to support that community, that wellbeing community, through the ACGME. The content of the calls evolved. It started really COVID focused, and then it evolved to more general wellbeing needs. And now it's shaped by things that are being published, things that people are working on, bringing in national experts, and then ideally bringing the community together to talk about what they're doing, what they think is working, what their needs are. So it's really an exchange of information between ACGME leadership, national experts, and people really doing the work for their GME groups and wanting to learn. It still exists. If you're interested in getting involved in it, I would suggest reaching out to Stuart Slavin or Bethany Alden at the ACGME. I can put Bethany's email right in the chat. You can all email Bethany. She'd be happy to involve you. It's a wonderful group. Thanks for the reminder to share that, Kira.
Yeah, thank you for sharing. So that's it for time today. I just want to thank both of you for joining us. I always wish we had a bit more time, but really a special thank you for being here with us today and sharing your expertise. I'll look forward to the next discussion we get to have. With that, I'll turn things over to Alec to close us out for today.
All right, thank you, Kira. Thank you to our wonderful speakers today. I just have a few things before we get going. When we conclude, you will see our feedback survey. Please take the time to answer the 2 questions there. Your responses will help guide our upcoming programming to deliver webinars you want to see, such as the one you saw today. This recording will be available to review on demand with the link you used to join today, including access to today's slides and recommended resources by selecting them in that dark toolbar as I described there and is also shown right now on slides. Our next webinar is 2 weeks from today, focusing upon optimizing onboarding in healthcare. Our expert speakers will help you develop a formal onboarding process that engages all key stakeholders and ensures new physicians and non-physician providers feel supported as they ramp up their clinical work. If you'd like to attend, you can register now by following the link in the Resources tab to register in one step. And finally, if you're looking for something a little more in-person to do from the Steps Forward Innovation Academy, we would like to invite all attendees to join us for our next Saving Time Practice Innovation Bootcamp in Chicago this September. This 2-day in-person bootcamp is specifically designed for clinical and operational change agents looking to eliminate unnecessary work and free up more time to focus on patient care. If you have interest in attending, again, you can follow the link in the Resources tab. For any additional resources and guidance and support for your physicians and staff, including those focused upon well-being, please visit the American Medical Association website or stepsforward.org. We thank you again for joining us, and we hope to see you again soon.